Okay, so welcome to Eat, Move, Think, the show about optimal wellness brought to you by Medcan.
Wow. Do it again.
Oh, I was practicing.
Okay, ready?
Welcome
to
Eat, Move, Think,
the show about
optimal
wellness
brought to you by
Medcan.
Yeah, this is extremely good. Thank you.
Hey, Chris, how are you sleeping lately?
On the days when I exercise, I sleep great. On the days when I don't exercise, I wake up in the middle of the night and think about work.
Interesting. And do you snore?
Yeah, I snore sometimes. Certain key people in my life have pointed out that I have a predilection for snoring. Yes.
That's often the first step to finding out that you have sleep apnea. There's actually 5.4 million Canadians out there who are at high risk of either experiencing sleep apnea or have been diagnosed with sleep apnea. And I think it's fair to say that a lot of those people don't know they have it.
That comes with long-term health effects, doesn't it?
There are some serious health effects that come with sleep apnea, especially if it goes untreated. It's associated with a 2 to 3 times increased risk of cardiovascular disease or metabolic disease. That's serious.
So long-term. And then I think people just have general fatigue too if you're suffering from sleep apnea.
And you're causing the people around you to maybe have fatigue as well, especially if you sleep with a spouse or you have people in the room next door who could hear you snore. Like that can definitely have an effect on your relationships too.
Okay, so I suspect I know why we're talking about sleep apnea, but why are we talking about sleep apnea?
Okay, well, today's episode is all about sleep apnea.
Many people may not know that they have it.
And how now, if you think you have sleep apnea, you don't necessarily have to go to the hospital and get yourself all strapped up to a machine for that awkward, uncomfortable sleep study. There's a new option now.
Amazing. I'm Chris.
I'm Jazz. We're the producers of Eat, Move, Think.
And in today's episode, we have
Dr. Chris Chan. We're really excited to introduce him. He is the clinical director of Medcan's new sleep program.
Dr. Chris Chan is a respirologist and sleep specialist. He's recognized as a sleep medicine specialist by the College of Physicians and Surgeons of Ontario, and he's a fellow of the World Sleep Society. And he holds board certifications by the American Board of Internal Medicine, Pulmonary Disease, and Critical Care Medicine. He is an assistant clinical professor in the Division of Critical Care at McMaster University. This is a bit of a special episode. We are privileged to be able to air a presentation by Dr. Chris Chan about sleep apnea.
And an exciting new way to diagnose it.
Absolutely. For those who may be thinking that they have it, or perhaps there's somebody in their life, a loved one, a friend, this is an episode for them. So here's Medcan sleep specialist, Dr. Chris Chan.
Thanks again for the organizer, for this event and, all the sponsor. And I also want to thank you, the Medcan team. The welcome has been overwhelming and they've been very supportive to get this program off the ground. So I'm looking forward to working with all of you in the months ahead, okay? So what I'm going to talk about today, the agenda is a bit ambitious. First, I'm going to quickly go over the clinical review of OSA. And then I'm going to talk about the technical aspect of sleep studies, including, the traditional polysomnography and also the home sleep study and how home sleep study is being applied in Ontario. And then I'm going to just touch base on a few clinical research data to support the utilization of a WatchPad for our program. So obstructive sleep apnea, as all of you know, is the most common sleep disorder breathing. And in terms of the epidemiology, is more common in men than women. Depends on what cohort and what references you looked at. I usually tell my patients about 1 in 3, 1 in 4 men are susceptible to have sleep apnea. For women, about 10 to 15%. And, for a patient who has underlying cardiovascular comorbidities like hypertension, heart failure, AFib, the prevalence is actually much higher. It can be like 40 to 80%. So how sleep apnea is characterized by the repetitive, partial, or complete collapse of the upper airway during sleep. So as a result, you can have a reduction in airflow. That's what we call hypopnea, or a complete cessation of airflow. That's what we call apnea. So to make the diagnosis of sleep apnea, basically all we do is just add up all these respiratory events, hypopnea and apnea, divided by the total number of hours sleep on a sleep study, and we come up with a respiratory index called AHI, the apnea-hypopnea index. So this is sort of the index we use to determine if a patient have a diagnosis of sleep apnea or not. So normal would be less than 5. Between 5 to 15, AHI is considered mild OSA. Greater than 15 is moderate. Greater than 30 is a severe case. The pathogenesis or the disease mechanism can lead to all the cardiovascular condition, probably even non-cardiovascular condition. If you have airflow obstruction, obviously you can have a lot of hypoxemia and hypercapnia because you're not breathing very well. And the swing in your oxygen saturation, these fluctuation is proposed that it can create some inflammatory cascade, endothelial dysfunction, hypercoagulability, and ultimately potentially can lead to accelerated atherosclerosis. Also, if you don't breathe very well, you don't sleep very well. So it can lead to a lot of cortical arousals and sleep fragmentation. That in turn can also predispose you to having metabolic dysregulation, activate your sympathetic nervous system. So that can cause a lot of hemodynamic changes during sleep, like your heart rate, your blood pressure can spike up. And when you're breathing through like an obstructed airway, there's a large swing in your intrathoracic pressure. And that in turn can cause more hemodynamic changes and ultimately, can even cause a cardiac remodeling, and you end up with all these disease conditions, and most of them are not reversible. So I think in terms of risk factors and clinical features, sleep apnea, for the risk factor, the main one is weight, obviously. Also, the key determinant is actually the craniofacial anatomy and your upper airway structure. Age, every 10-year increment, you have a high likelihood of developing sleep apnea. For women, also postmenopausal state with the hormone changes that can also increase the risk of developing sleep apnea in middle-aged women. In terms of clinical symptoms, oftentimes patients will complain, excessive daytime sleepiness or fatigue, unrefreshing sleep. A lot of people would complain about snoring at night or even having respiratory symptoms at night, like choking or gasping, as well as a morning headache and acid reflux symptoms at nighttime. So because of the high prevalence of cardiovascular disease and obstructive sleep apnea, even the American Heart Association made recommendation for screening sleep apnea. So a patient who has, refractory hypertension or pulmonary hypertension or recurrent AFib, they should probably get a sleep test just to exclude, sleep disorder breathing. If they have symptoms and, these kind of cardiac arrhythmia conditions or stroke, certainly they should be have a very low threshold to go through sleep testing to rule out OSA. We actually get quite a bit of a referral from ophthalmologists. So a lot of ocular conditions, such as floppy eye syndrome, glaucoma, papilledema, retinal condition. These are all linked to undiagnosed or untreated sleep apnea due to the hypoxemia. For ENT colleague, they often send us a referral, patients complaining of tinnitus or hearing impairment, nasal congestions, hypothyroidism, because it can cause hypoventilation, chronic lung disease, chronic kidney disease, fibromyalgia, acid reflux. These are all kind of fairly common referrals to the sleep clinic. For women, pregnancy certainly raises the risk of developing sleep apnea, especially later term, due to the enlarging uterus and the hormonal changes and the fluid retention in the upper airway. PCOS is also another one. We talked about menopause already. We know for sure, there are patients who have even severe sleep apnea, they are truly asymptomatic. So I kind of give the percentage about 20 to 25%, okay? So you can walk in around with an AHI of 50 and still functioning as a truck driver, clean record, never a car accident. Or you can have a patient who have very mild sleep apnea or even upper airway resistance syndrome, and they can be severely symptomatic, okay? So definitely, sometimes I do trust the patients, that I'm fine, I'm not tired at all. And the only reason why I'm doing this is because my wife said I snore, right? So, and also snoring, the patient themselves cannot assess themselves, right? But then I would explain to the patient, yes, I know you don't have sleep apnea symptoms, but those patients traditionally are harder to treat because, if they're asymptomatic, it's hard to convince them to wear the CPAP, right? So that's when the counseling, the education comes in and say, hey, you belong in that group of asymptomatic patient, but you're also at risk for a heart attack and a stroke. So the most common site of obstruction in the upper airway is in the retropalatal region as well as the retroglossal region. So if you have a patient who has an elongated palate or, they have a large, fat accumulation in the base of the tongue, certainly can obstruct the airway. If a patient like this, who undergo, say bariatric surgery or dramatic weight loss, they lose a lot of fat, there's a good likelihood that their AHI could certainly improve. Some patients, they would tell you after losing weight, they still have the sleep apnea symptoms or they don't get better, most likely because it's due to some sort of bony structure like, retrognathia or micrognathia that is obstructing the airway. Next, after you do the history physical, you refer the patient to the sleep clinic. We have the polysomnography, of course, is the most common test conducted in a sleep clinic. Of course, through the sleep lab, we can also offer home sleep study, but it's not very commonly done, I would say, because it's not covered by OHIP. And, when you do a full night sleep study in the sleep lab with technologists, spending the night there, collecting the data, the troubleshoot of the problem, this is what we call like a level 1 sleep test. And a level 2 sleep test is not very commonly done. Actually, never seen it done in Ontario, maybe like in the research setting. So the home sleep study that what we're using is considered level 3. So during a sleep study, we'll collect all the data. The key thing, what we're trying to figure it out is the sleep staging. So we want to decide, the patient, how much sleep they get, during that night, how much REM sleep, non-REM sleep, how many arousals, wakefulness, so we can assess that during the sleep study, through the EEG channels. And we also want to, assess the respiratory disturbances by measuring, apnea and hypopnea, upper airway resistance. We also, check for limb movement to rule out any sleep-related movement disorders. So if the patient was deemed to have sleep apnea and we decide to go ahead and treat them with a CPAP machine, in Ontario, the CPAP machine purchase is actually, you get a subsidies through the assistive device program. So the patient will get, some subsidies. But the key to have this form checked is that you have to have a level 1 sleep test. So home sleep study, unfortunately, will not qualify you for this subsidies to buy the CPAP. So now that you're all expert in PSG, I'm going to jump to, home sleep study. So home sleep study is outside Ontario has been doing for many years, in the States and even other provinces. There's a lot of literature that support its use, mainly in the patient population without any other kind of significant sleep disorder or medical comorbidities. The technology is evolving. So, the question about home sleep study is you always want to pick the right one and, make sure the quality assurance is in place. The advantage, of course, is very accessible. It's easy to do. Patient, like to sleep at home and, they don't want to come into the sleep lab. It's cheaper to do, especially in the States because you don't have a technologist overnight to collect the data and also give you the option to do it, multiple times. And most importantly, because most of the home sleep study device, they don't check the EEG. So it's hard to determine how much sleep the patient actually got at home, that night. Most home sleep study will generate an index called REI, or Respiratory Event Index. So basically, they would add up all the respiratory disturbances and divide it by the total number of hours of recording. So the recording time is always going to be greater than sleep time, right? So that's why, oftentimes a home sleep study will give you an underestimation of the actual AHI that the patient has. So WatchPad is very unique in that way because, this home device actually can also estimate sleep. So that's why, WatchPad, they're able to also generate an AHI that would be in a closer approximation of the actual AHI of the patient. So there's a lot of society that publish guidelines on, the clinical usage of home sleep study. American Academy of Sleep Medicine is, in our world is a big one, AASM. So they publish, guidelines on how to use these sleep tests. Mainly, it is a medical test, it has to be ordered by a physician. It has to be used in conjunction with a history and physical. And a certified sleep doctor has to sort of make the determination of whether a patient have sleep apnea or not. And they also made some guidelines in terms of using a home sleep study, not just in diagnosis, but you can use a home sleep study to follow up. Okay, so you can follow up patients who's on CPAP already. Why are they still having residual symptoms? For non-PAP interventions, if there's any weight gain, weight changes, or any change in the cardiovascular status, home sleep study along with full PSG is an option for the work of the patient. The condition they recommend using home sleep study as an option would be a patient who has moderate to high pretest probability of having OSA, or the patient just simply cannot come to a sleep lab. If they are wheelchair bound or if they're homebound, they can come in, for example. So home sleep study would be an option in these patient population. Situation they don't recommend using home sleep study would be general screening for asymptomatic patients again. If a patient have a lot of comorbidities such as neuromuscular disease, heart disease, chronic lung disease, because it can degrade the accuracy of the data. Also, they don't recommend using a home sleep study to look for other primary sleep disorder like narcolepsy or central sleep apnea, chronic insomnia. And it is not validated in children, so it's mainly used for adults only. So WatchPad is the device that we decide to adopt at the Medcan sleep program. Again, because of the technology, allow us to actually estimate sleep. And the concept is to use this finger probe to measure the peripheral arterial volume change or the vascular tone. So using this kind of PET signal in conjunction with the change in the heart rate, the actigraphy, the snoring, the SpO2, the device have an algorithm that can determine if the patient is awake, in REM sleep or in non-REM sleep. So now I'm just going to go over a few studies that sort of support the use of the WatchPad in home sleep study. One, basically, they look at after transitioning to a home sleep study using WatchPad, what is the impact on the healthcare system? The test availability, the wait time, patient satisfaction outcome. It was done in 2014. The study was based in Israel. So they look at one of the largest health insurance provider and extract about 650,000 patients, or a lot of numbers. Basically, what it shows is after the transition, there's a significant increase in sleep study orders, so by 90%. So the accessibility of sleep study dramatically increased. But despite the more tests were being done, the overall cost went down by 20% because it's cheaper to do a home sleep study than doing a full PSG. And the wait time for a PSG went from almost from 10 weeks down to just over a week because of improvement in the accessibility. And also there's more CPAP purchase after the home sleep study was implemented. There's a 40% increase. So more patients are being diagnosed, more patients are getting treatment. And the overall outcome, in terms of compliance, CPAP usage, in terms of improvement in daytime sleepiness and quality of life, patient satisfaction, they're all pretty much very similar using a PSG compared to a home sleep study and making the diagnosis. And when asking the patient, if they want to do an in-lab test or a home test, majority of patients actually want to do a home sleep test. It's just more comfortable and more convenient to do it at home. And using the WatchPad, even for different subject group, normal, mild sleep apnea, moderate sleep apnea, severe sleep apnea, the agreement using WatchPad was all over 80% in all the different subgroup of patients. So definitely is very reassuring that a WatchPad does a very good job in making the diagnosis correctly. This study also basically showed that the WatchPad was able to, have a very good ROC in picking up any residual moderate to severe sleep apnea. And using WatchPad, they were able to pretty much pick up most of the patient, having residual symptoms. And the last study I want to go through is using WatchPad to assess for surgical results outcome. Not only you can use CPAP to treat sleep apnea, there's surgical options. And this study looked at about 35 patients who underwent sleep surgeries. So they would do the WatchPad before and after to see if the results would be in agreement with the improvement in patient symptoms. So after the surgery, the patient got put on the WatchPad. For most of the patients, I think about 28 patients, there's a improvement in their AHI, the RDI, and the oxygen saturation. And those 28 patients also reported having improvement symptoms. So this study basically supports that using WatchPad, you can also use it to assess the treatment results from sleep surgery. Okay, so take-home message, hopefully this talk would bring up some points for you to take home to improve your history and physical and identify the patient who is susceptible to have obstructive sleep apnea. In the Medcan program, right now, what we're trying to do is focus more on, sleep apnea And I will see the patient, do the full consult, and I will decide if the patient would want to go for a home sleep study, if they're a good candidate for a home sleep study, or if they need to get a full PSG, I can refer them to affiliated AHF or any sleep lab of their liking or close to their geography. And the watch pad that we choose to use for our program is an excellent home sleep study device. And it's very unique, like I said, because mainly it can stage sleep and give a very accurate diagnosis of sleep apnea. And we can use a home sleep study both for diagnosis and longitudinal care for sleep apnea patients. Thank you so much.
That was Dr. Chris Chan, Clinical Director of Medcan's new sleep program.
If you struggle with sleep, or if you want to know if the new at-home sleep study is right for you, contact specialty team at medcan.com for more information.
Follow Medcan on Twitter and Instagram at MedcanLiveWell.
We'll post episode highlights and other links so you can visit on our website, eatmovethinkpodcast.com.
Say hello and send us a tip or a suggestion by emailing us at info@eatmovethinkpodcast.com.
Eat Move Think is produced by Ghost Bureau. I'm Jasmine Ratch, managing producer.
Social media and strategy support is from Chantal Gertan, Andrew Imax, and Emily Bozick.
As well as Amanda Serafina James and Naman Dutta.
Executive producer is me, Christopher Shulgin.
We will be back soon with another episode examining the latest in health and wellness. This podcast episode is intended to provide general information about health and wellness only and is not designed or intended to constitute or be used as a substitute for medical advice, treatment, or diagnosis. You should always talk to your Medcan healthcare provider for individual medical advice, diagnosis, and treatment, including your specific health and wellness needs. This podcast is based on the information available at the time of preparation and is only accurate and current as of that date. Source information and recommendations are subject to change based on scientific evidence as it evolves over time. Medcan is not responsible for future changes or updates to the information and recommendations and assumes no obligation to update based on future developments. Reference to or mention of specific treatments or therapies does not constitute or imply a recommendation or endorsement. The links provided within the associated document are to assist the reader with any specific information highlighted. Any third-party links are not endorsed by Medcan.